Okay, good afternoon, ladies and Looney Tunes. My name's Danny Whitaker. This is the My Own Worst Enemy podcast, where it's my job to sit down with some of the biggest and brightest minds in the area of mental health research and hopefully provide you guys with some information and advice to help you improve your own mental well-being. So, we made it. Episode 2. I think it's been about a month since we posted the first episode on depression, which isn't quite as frequent as the once a week I initially planned. But good news is, in the past week, been a bit of a busy boy. Managed to get 4 interviews recorded. So we should be good for an episode once a week now for at least the next month. So look out for those. Okay, so today we're talking about psychosis, which might seem quite a conceptual leap from the first episode. The first episode, we talk about depression, which is, one of the most common and kind of well-known mental health issues. And then episode 2, suddenly jumping straight to psychosis, which is at the more extreme end of the spectrum and a lot less well understood. And you might be thinking, hang on a minute, what about all the stuff in the middle, like, anxiety and agoraphobia or OCD or all those kinds of things? Well, don't panic, no pun intended. We will be getting to those. I mean, okay, here's the thing. Look, when I first conceived of this idea, I did quite like the idea of kind of doing it in little box sets sort of thing. So with this first series of episode, I wanted to do all the different mental health conditions. And then, that'd make a nice little box set. And then the next series would kind of maybe be about different therapies and or different schools of psychology and stuff. And then series 3 would be about, pharmaceuticals and different medications or something like that. Now, it's a nice idea. And it's not that I've had any issues with getting people who are willing to come on and talk about these things. If anything, I've been pleasantly surprised by how willing different academics and researchers have been to get involved in this project, considering, it's very early days at the moment. So the problem isn't getting people to talk about these things. The problem is in scheduling, because these are busy people. And, it's one thing to invite people on and get people to talk about things, but it's a whole other thing entirely to try and get people to come on in a particular order on a particular day. So I'm afraid that kind of very nice, neat, structured approach to the podcast has gone straight out the window, I'm afraid. So what I'm doing instead is I'm just talking to people in whatever order that they happen to be available. And inevitably, that's going to result in absolutely no structure whatsoever. 1 week we're going to be talking about anxiety. The next week we might be talking about, hypnosis. And then the next week talking about selective serotonin reuptake inhibitors. And we're going to be all over the place. But you know what? You're just going to have to get what you're given for the time being. Because like I say, right now, no one knows who I am. No one cares. And I've got absolutely no reputational leverage whatsoever. So that's that. But anyway, like I say, today's episode, we're going to be talking about psychosis. And my guest on that topic is Professor Alison Yung. Alison is the Professor of Psychiatry at the University of Manchester. She's Honorary Consultant Psychiatrist at Greater Manchester West Mental Health NHS Foundation Trust, and she's Director of Undergraduate Education for the Institute of Brain Behaviour and Mental Health at the Manchester Medical School. In 2009, she received the Lilly Oration Award for prominence in psychiatric research, and in 2010, she was the recipient of the Richard J. Wyatt Award for remarkable contribution to the area of early intervention. She's the author of more than 150 publications, a body of work which in 2014 helped her make it onto the Thomson Reuters list of the world's most influential scientific minds as one of the 100 most highly cited researchers in the field of psychiatry and psychology. So, quite a resume. As with the episode on depression, this should be considered a kind of introduction to the topic of psychosis. It's very broad, lots of different topics covered. Things like, what is psychosis exactly, defining psychosis. We talk about the different symptoms and manifestations of it, hallucinations, delusions, etc. We talk about media depictions of psychosis and whether or not they're accurate or is it just all Hollywood spin. We talk about whether or not you can be predisposed to a psychotic episode, different kinds of triggers, whether it's a lifetime of stress or, can it just be one bad trip off that dodgy joint behind the bike sheds when you're 14? And most importantly, can people make a full recovery? So, if you'd like to comment on anything we talk about in this episode, you can do so by going to myownworstenemy.org/podcast. And without further ado, here's my interview with Professor Alison Yung. Okay, Alison Yung, welcome to the podcast.
Thank you, Danny. Very nice to be here. Thanks for inviting me.
So, we're here today to talk about psychosis, which before we get into any kind of definitions of what that is and exploring what it is, from my point of view, psychosis seems to be, well, two things. It's the most stigmatized mental illness. I think it's probably the most feared as well. As somebody that's had mental issues myself, that was the point I feared reaching, if you like. And in general, it's just, in researching this interview, it was almost a kind of unnerving experience. So my question to you before we even delve into it is, why psychology? Why psychosis specifically?
Okay, thanks, Danny. Well, first of all, it's psychiatry that I'm in, not psychology. Minor difference. Okay, so, well, it all started actually when I was a junior doctor. And this is back towards the latter half of the last millennium, so some time ago. And I was working in a hospital in Melbourne, and I was doing a term of psychiatry. And I came across a lady who was so unwell with psychosis that she had poured boiling oil over herself and she had burnt her own arm off. And I just thought, how does somebody get so unwell that they would do that to themselves? Can we make it so that they don't get so unwell? Can we prevent that from happening? Yeah. Can we minimise the impact of the psychosis? And I've been interested in it ever since then.
Wow, that's exactly the kind of thing that would kind of scare me about it. What was your general interest before that?
Before that, I was actually thinking of going into pathology, so looking at cells and very far away from human interest. But actually having that experience really changed my direction completely. Okay,
so what would be a good definition for what psychosis is? Is it a thing that you can? Is it the same as depression? It's a condition that you have psychosis, or is it more of a symptom of another underlying mental health condition?
Okay, so that's a tricky question. Psychosis is a syndrome, so it's a collection of symptoms. The main ones are things like hallucinations and delusions. So hallucinations are where somebody perceives something, but there's nothing actually there. So they might hear a voice when there's nothing there, or see a vision when there's nothing there. And to them, it sounds exactly like an actual voice, or seems exactly like something there.
Yeah, well, I mean, let's we'll just stop on that idea of hallucinations. Now, This is, I think most people's idea of hallucinations they'll get from films and TV and stuff. Good examples of this are films like Fight Club. The narrator in Fight Club, I don't know if you've seen that film.
I haven't seen Fight Club, actually, but somebody told me what happened, so I can never see it now because it's been ruined for me.
Right. Another one is the main character, Elliot Alderson in Mr. Robot. That's the point is, those characters, they see and interact with their hallucinations as real things that can be touched. They fight with the characters and they have scuffles and stuff. And when people are hallucinating, is that how real the hallucinations are? Or is it more, for instance, I've got a little boy, 6 years old. I can picture him now standing next to you, almost as clear as day, if you like, but there's still something ethereal about the way I'm imagining it. Is that how people hallucinate, or is it as real as you're sitting in front of me now?
Well, at the extreme end, so true hallucinations, they seem like a true perception. So it's like you hear a voice so real that you'll turn around to see who's calling your name or to see who's talking to you. So it sounds exactly real.
Yeah.
Whereas you know that there's nothing really, your little boy's not really here. You're just sort of picturing him in your mind's eye.
Yeah.
It's different from that. But we do know that actually hallucinations can occur on a continuum. So you've got these true hallucinations that seem exactly like the real thing, so that people can't distinguish them from the real thing, through to more sub-threshold forms of hallucinations. So somebody might say, well, I'm not sure if it's a voice or if it's my thoughts. So sometimes it sounds like a voice, but actually then I realise that it's really just me thinking, but it's louder than my normal thoughts.
Ah, interesting. See, again, another way of kind of thinking about that would be, I can picture somebody talking in my mind now, or listen to a song. I can hear the drums, the notes, the singing, and I can hear it very, very clearly. So would that be, again, is somebody with the hallucinations, are they experiencing that more real than I can hear music in my head, or are they just kind of perceiving it differently?
No, they're hearing it as more real. So it's like the bit of the brain that normally receives input from your ears is being stimulated by nothing at all. So
wow.
So they're actually hearing something that isn't there.
Is it similar to, is it similar to maybe dreaming, where there's no sensory input going on, but it still feels real? It's you can smell and touch and see things. Is it like a waking dream, I guess?
Yeah, I don't know that I would describe it as a waking dream, but it's in the same realm as there's no stimulus coming in. So the definition of a hallucination is the perception in the absence of a stimulus.
So then, I guess then that these media portrayals of characters hallucinating are actually kind of a fair portrayal of it.
Well, yes and no. The most common hallucination is an auditory hallucination, so something that you hear. That doesn't make for very good TV usually, or good film. So they usually show in TV and films the hallucinations as being a combination of visual, so something you can see, as well as something that you can hear. So normally you would probably just hear something rather than see it and hear it.
Okay. Next one would be delusions.
Yeah, so delusions are the other prominent symptom in psychosis, and the definition of a delusion is a fixed false belief. So people genuinely believe with 100% conviction that something is happening that's not actually happening. So commonly they might think, for example, that people are poisoning them, or they might think that GCHQ is spying on them.
So kind of paranoia.
So, yeah, those sort of ones I just described are paranoia. There's other delusions that are even more disturbing for people, and these are things such as that people can read your mind, or that thoughts are leaking out of your head and other people can know what you're thinking, that somebody is taking the thoughts from your head. And if you just think about that for a minute, you can understand how disturbing that is, to think that really what should be your own private space in your head is accessible to other people. So it's a very distressing type of symptom.
And do people kind of look for evidence of these delusions, and then because they're looking for them, they'll find them, if you like? Or is it just, or can they have delusions with a complete lack of evidence as well?
So I think you're right there, Danny. People... there is no evidence really for these delusions, but people look for evidence. And you can imagine if you walk down the street and you are thinking, everybody hates me, everybody's looking at me, and then you start looking at people, they'll look back at you.
Yes.
So then you see evidence really where there isn't evidence.
Like a confirmation bias.
That's right.
Yeah. Oh, the other one was delusions of grandiosity.
Yeah, so grandiose delusions, or delusions of grandeur. So this is where people think that they're especially important in some way, or they've got special powers. And it can be quite extreme. You know, people can think that they can fly, that they can cure illnesses, sometimes even that they are somebody who's specially important. So they might think that they are Superman, that they can communicate with God, that they've got special positions. So.
Okay, interestingly then, I mean, that sounds... I mean, you could say that certain public figures are guilty of that. When would the idea of of grandiose thinking, when would that become pathological instead of just a bit egotistical? What the distinction?
So this is what we are increasingly understanding, that you, again, like hallucinations, delusions can occur on a continuum. So you've got at the one end, people are 100% convinced that they are a messenger from God, or 100% convinced that they have superpowers. But then, on a lesser extent, people might just think that they're especially important and are the only person that can save the country, for example, through to, there's such a thing as jealous delusions, where people are absolutely convinced that their partner's having an affair. They would be checking the phone, they'd be following them around, they'd be stopping them from going out. And you can see, jealousy is a normal part of most relationships. Yeah. So it's only when it gets really extreme and really interferes with that relationship and is really cannot be dismissed at all, where we would say it's a delusion.
Right, okay. The next one, again, used a lot in films, is catatonia. And I believe that can manifest in two different ways as well, as immobility or as erratic behaviour. I think the most common one is this image of somebody sitting in a chair, usually in a mental hospital, and just won't move, won't interact with people, and kind of staring off into space. Is that an accurate portrayal, or?
We actually don't see a lot of catatonia anymore. So catatonia is thought to be a motor manifestation of psychosis. So like you say, Danny, one form of it is really people not moving, not responding. People could put them into positions like their arms raised and they wouldn't return to a normal position. And as you said, the other one, catatonic excitement, so people running around. These are really things that occurred probably in the 19th and early part of the 20th century, and strangely we don't see those sort of symptoms anymore. It's not entirely clear why that's happened. I did see one case of catatonia when I was training to be a psychiatrist, which was very interesting. It was a young man who didn't move, so he was lying down. His pulse rate was very, very high. He was sweating, but completely didn't move, to the extent that he wasn't eating or drinking. So it was quite dangerous for his health. When he got better, I actually asked him, what was going on when you were not moving like that? And he said to me that when he was like that, he thought that there was a lion lying on his chest with its jaws around his head, and if he moved, it would bite his head off.
Wow.
Yeah, so in that case, he presented as having catatonia, but it was actually a combination of a delusion and a hallucination that had put him like that. Is there
any kind of speculation as to why it's not seen anymore and why it was a thing of the 19th century?
Yeah, I was worried you were going to ask me that because I don't know the answer.
Okay.
It's just a very interesting phenomenon that we just don't seem to see that. It may be that we don't see that anymore because the treatments have improved, so that it might have been a manifestation really of very severe illness. And this was happening a lot before we had medication to treat the symptoms of psychosis. So it might just have been that we had very severe form of psychosis that manifested as catatonia, but I can't actually tell you the answer to that.
Yeah, interesting though, definitely. The last one was disordered thinking.
Disordered thinking.
Yes.
Yeah, so disordered thinking is another symptom of psychosis. And this is where people really stop making sense when the thoughts in their head and then the way that they try to communicate with people come out, instead of, our thoughts kind of being in a straight line, they can seem to be going all over the place. One theory about it is that words lose their symbolic meaning. So usually if I said to you, think of a carrot, you would think of an orange vegetable. But when words, and that's where you've associated a symbol with a word. But if words lose their symbolic meaning, it means that you hear the word carrot and it doesn't have a picture of a carrot for you at all. So you're kind of treating it as the carrot, the hard carrot word. And you might be thinking carrot, car rotting.
Well, a lot of people might have an experience of this anyway, if you sometimes just say a word over and over and over again, it dissociates itself from that symbolism, if you like, and just starts to sound strange with the repetition of it.
Yeah, that certainly can happen. And also, if you think of surnames, that's where words have lost their symbolic meaning, haven't they? Because if you think of some surnames and then you think of what they actually mean, they're kind of weird. So if you think of, I think there's an English cricketer called Sidebottom.
Yes.
Now, we would normally say his name and we wouldn't start chuckling. Until you think Sidebottom.
Yes, interesting. Yeah. Okay, well, I'd kind of like to cover just the kind of the basic epidemiology, if that's the right word, of kind of who tends to be affected by psychosis, and say, for instance, what percentage of the population will have psychosis at any one time, and then what percentage of people over the course of the lifetime are likely to suffer from it.
Okay, so as we were discussing, Danny, psychosis is a syndrome with these hallucinations, delusions, disordered thinking. Hallucinations and delusions are actually quite common in young people. So if you actually surveyed the general population, at any one point in time, people aged 18 to 24 would have probably a 25% rate that they would have experienced those sort of symptoms at some time in their life. So where it becomes a problem is really where these symptoms persist and where they're associated with distress and with difficulty in performing everyday tasks. So there's really a difference between psychotic symptoms, which are not that uncommon in the general population, and psychotic illness or psychotic disorder, where it becomes a problem.
What would be what would be classed as psychotic-like symptoms that were regular, if you like, that would, like you say, amongst the general population, but that doesn't affect somebody's life?
So if you actually ask, say, a group of 100 young people aged about 20, and you say, have you ever heard a voice when there's nobody there? About 25 of them would say yes. And this can be something like they just were walking through a busy street and they thought they heard somebody call out their name. It was real enough that they kind of turned around, but there was nobody there. Or you might say, have you ever thought that people are out to get you or are giving you a hard time? And they would, at some point, life is stressful, and people would say, at one point I was really quite paranoid and I thought nobody really liked me at school and they were just pretending to be my friend. But I'm kind of over that now. So those sort of symptoms, as I said, are not that uncommon. Where it becomes a problem is where they do persist, where they're distressing, and where they're the person really wants some help with them. That's where they're affecting their life to that extent that they do need some help.
And what percentage of people would you say get to that point?
It's probably only a very small minority of the people who actually experience it would have those persistent and, I guess, disabling effects of the psychosis. So probably like less than 10% of people who have psychotic experiences actually go on to develop a psychotic disorder.
Oh, wow, okay. And is there any disparity between the genders, if you like? Are men more likely than women, or...?
I don't think so. I mean, it's still really early days in this research, and, you'll get symptoms that might go along with the psychosis. So depression is certainly more common in women. So if you have psychosis plus depression, that might be more distressing than if you just have psychotic symptoms.
And there is a kind of a tendency to be like the age of onset tends to be in young people for the first instance of psychosis. Is that right? So
yes, we talk about so it's really the first episode of a psychotic disorder. So we call it a first episode of psychosis, and that's where somebody does need some help and where they are disabled and distressed by those sort of symptoms. And as you said, Danny, that does tend tragically to occur in young people for the first time. So people in their late teens and early 20s.
Do we know why that is?
That's an interesting question. Why is that? And I mean, it's a time of a lot of change in people, both biologically and psychosocially. So it's a very stressful time, unlike the Pepsi ads. That sort of age is where people are trying to work out who they are. They've got stresses of exams and what they're going to do with their life, with trying to move away from their parents and their family of origin to striking out, new romantic relationships, identity type issues. So there's all those psychosocial factors that are occurring around that time.
Is the brain still developing at that age as well?
Well, that's right. That's the other thing that happens, is that we've got the young people have got these impulses, and impulsiveness, it's probably an evolutionary advantage to have some impulsiveness as a young person, because it means that people do strike out and take risks and move away from the family. But at the same time, you've got this impulsiveness without, the typical middle-aged type thinking that kicks in, where you're going, maybe you shouldn't do that, or this might happen, that might happen. That sort of planning and sequencing and weighing up the different risks that occurs later on. So the brain is actually still developing up until about the age of 25. And that final part of the brain that develops is the last part of the frontal lobe, the bit that sort of is responsible for abstract thinking and logical type thinking. So you've got impulsiveness without that kind of break on the impulsiveness. So there's biological reasons and psychosocial reasons that are all occurring around this time.
So does that mean that, say if you're lucky enough, if you like, to get to 25, 30 years old and you haven't had any kind of psychotic episode, it means you're much less likely to suffer one going forward? So
the risk does go down. If you've got to the age of 30 and you haven't had a psychotic episode yet, you're probably not going to have one. You're not quite out of the woods. There are cases that occur later on, and probably as people develop other stresses throughout later years, but really much less likely. And if somebody has an episode of psychosis after about the age of 40, we would start thinking, this isn't your normal sort of psychosis. Is there something else going on? Has this person had a stroke? Have they got a brain tumour? Is there some kind of actual problem with the brain or the nervous system that's causing this? So it would be quite atypical for a first episode of psychosis to really occur later in life, though of course we do see that.
Okay. So I'd like to move on to what the causes are and kind of diagnosing psychosis. So my little bit of research I've done is this speculation about genetics, trauma, substance abuse, stress, all manner of different things. But which would be the primary causes?
Well, I think you've just answered your own question with that whole list of likely suspects there, Danny.
Is there some that are more likely than others, though?
So a useful way of thinking about it is really what's called the stress vulnerability model. So we all have a degree of vulnerability to develop mental health problems. And the vulnerability comes from a combination of genetics and early life experiences. We now know that there's not one single gene for psychosis or for psychotic illnesses. There's probably hundreds of genes, all of small effects. So we're all walking around with some of the genes that can predispose to psychosis. Some have more of these vulnerability genes than others. But having the genes isn't enough to bring on a psychotic episode or a first episode of psychosis. So we also think about vulnerability in terms of early life experiences. So what happens in the womb? So an interesting finding is that if the mothers have a flu-like illness in the second trimester of pregnancy, that increases the risk for the offspring to develop a psychotic illness. So there's something about that virus affecting the developing brain. We also know severe starvation of the mother while there's a baby developing predisposes to psychotic illnesses. So there's something about that vulnerable time in the womb, and also birth trauma. So again, things that happen around the time of birth can predispose to psychosis. And then there's the factor of early childhood adversity and childhood trauma, ranging from neglect, emotional abuse, sexual abuse, through to there's also increased risk with child adversity, with living in poverty, living in a stressful environment. So they're the sort of vulnerability factors that we talk about. And then there's the stress on top of that.
But just to clarify, just because you've had a difficult childhood, it's not inevitable.
It's certainly not inevitable. And in fact, most people who have a difficult childhood, in fact, most people who experience awful childhood trauma actually develop no mental illness at all. So it obviously interacts with other factors. People have different levels of resilience. But then, so none of this stuff is is necessary or sufficient. And then you have a second hit around adolescence, late adulthood, of all those stresses that we're talking about. And second hits can also be in the form of substance abuse. So we know that there are some drugs that do increase the risk of psychosis.
Okay, what would they be?
So things like cocaine, crack, speed, and even cannabis.
Yes, that's just reminded me of experimented as a teenager with different substances. I've had a couple of scary experiences with substance abuse, and in it, when it's happening, you feel like you're losing your mind, that you're gonna snap. And so, yeah, my question relates to that, this idea of snapping. So if you've when you're talking about substance abuse, is psychosis likely to kind of rear its head after prolonged use, or can it be from just one bad trip that will kind of push you over the edge? Maybe a way of thinking about it.
Yeah, I hate to sound like a typical psychiatrist, but it's never really simple, and there's this sort of idea of the gene-environment interaction. So some people, they can have, heroic industrial quantities of all manner of substances and be fine, where you've got other people who they've got various vulnerabilities, like we were talking about before, and it really doesn't take much substance use to tip them into a psychotic illness.
Right, okay. And, the same for stress as well. Would it be a kind of prolonged stress would bring it on, or a stressful event? Can a single day break a person, if you like?
With stress, we know the problem with stress is where it becomes chronic, which is probably why children in adversity, especially if they've got already an underlying vulnerability from their genetic makeup, where they might be susceptible to prolonged stress, chronic stress, and it's just going on with no respite. And we know that actually chronic stress does change the way the body reacts. So chronic stress causes an increase in the hormone cortisol. Cortisol affects the brain. The developing brain might in fact be very susceptible to that. So that's probably why we see social adversity and chronic trauma having that effect on some people who are particularly vulnerable. And people also are known to be then develop more sensitivity to stress. So something that might normally not be a problem might actually be extremely stressful for them. So minor hassles, a debt, a bill that hasn't been paid, something that normally somebody might be able to handle okay, when that's on top of everything else, that can tip somebody over the edge. So one stressful event generally wouldn't have that effect, but it depends on if that's occurring on the background of chronic stress.
Right. So one thing I did come across in the basic research I did was this idea of functional versus organic psychosis. So functional being psychosis being brought about as a mental illness, and then the organic being the result of like brain injury or some sort of brain condition.
Yeah.
And the same way that I believe schizophrenia changes the actual structure of the brain, does the same happen with psychosis? Does psychosis cause a change in the structure of the brain, or is it the result of a change in structure in the brain? I know that's a very garbled question, but
So we were talking about psychosis as a syndrome, and there's a whole lot of different types of psychosis. So you've got, brief psychosis that might last less than 24 hours and go away. So somebody's had psychotic symptoms and they just go away. Maybe they've been brought on by having a very stressful time and using a lot of substances, Glastonbury or something like that. So that's one type of psychosis. But on the other hand, schizophrenia is actually a psychotic disorder. So that's generally thought to be much more severe, long-lasting psychotic illness. And you've got all sorts of psychotic illnesses in between. So you've got psychotic illnesses that might last anything from a month to sort of 6 months, have a generally reasonable course, but be vulnerable to relapses. You've got psychosis that's associated with depression. You've got psychosis that can occur with bipolar disorder. So psychosis is a very broad umbrella. and there's lots of different types of psychosis underneath that umbrella. And you talked about organic psychosis. So we also know that there are some brain diseases that can cause psychotic symptoms, and even some medication that's used for treating organic illnesses that can cause psychosis. So a common one is treatment for Parkinson's disease. They use something called levodopa that can cause psychotic symptoms. You've got, brain tumours, brain infections. They can cause psychotic symptoms. And the psychotic symptoms generally go away once that organic illness is treated. But in terms of what's the effect of these kind of non-organic psychotic illnesses on the brain, as you said, Danny, they are associated with brain changes. Now, whether that's the psychosis causes the brain changes or the brain changes causes the psychosis, we don't really know. We don't really know if they are reversible or not. So there's so much still unknown about these psychotic illnesses.
Okay, so we're going to move into the early stage psychosis now, which I know much of your research is involved in intervention and prevention. Let's start with what would be some early symptoms, what were some warning signs, if you like, that somebody's about to enter into a psychotic episode? I don't know if that's...
Yeah, that's one way of framing it. So I was talking before about how psychotic symptoms are not all or nothing, that they do occur on a continuum. So at the one hand, you've got really severe psychotic symptoms, but that we also see sub-threshold forms of them. So, rather than being 100% convinced that everybody's out to get you and wants to hurt you, it might start off as somebody being very self-conscious. They go out, they think, oh, people don't like me, they're looking at me funny, do they want to hurt me? Oh. And then, they'll kind of go home and they go, oh, that was weird. I was being a bit paranoid there, but, looking back on it, they were looking at me because I was looking at them. So the early warning signs are really those sub-threshold forms of psychotic symptoms, which we know that we can pick up. So rather than somebody saying, I hear a voice, it sounds exactly like a true voice, somebody's telling me, commenting on all my actions, it would be more like somebody saying, I can hear whispering or murmuring, but I can't work out what they're saying. Or I can hear something, it's probably my own thought, but then sometimes it sounds much louder than my normal thoughts. So it's those sub-threshold forms of psychotic symptoms that we now know that we can pick up. If we ask people about it, they can describe them. And they are risk factors for going on to develop a full-blown psychotic illness. But we also know that they might not go on to develop a psychotic illness. Those symptoms might go away by themselves, or they might actually be amenable to treatment, and we can prevent that first episode.
So you've designed a system for detecting this early psychosis in people, which is the at-risk mental state approach.
That's
ARMS.
Right. Yep. So
if you could tell me a bit about how you developed that, and then its kind of application in the real world.
So this work in trying to detect the at-risk mental state really came about from when I was working with young people with early psychosis. And I did a study that was asking them, so they'd recovered from their first episode psychosis, they were able to reflect back on the whole experience of becoming unwell and then needing to get treatment. And they were able to tell me what sort of symptoms occurred in that lead up to their first episode. So I started asking them, the first question I usually asked after, hi, how are you, was, can you remember the last time you were perfectly well and what happened leading up to that first episode? And so they were able to recount, often years of history of stress, depression, feeling that they weren't coping so well, trouble at school or just trouble just enjoying their everyday life. And then they were able to describe how things evolved from feeling very self-conscious into feeling that people really were out to get them, or feeling that things were special for them, to becoming convinced that there were things in the environment that were put there especially for them, from feeling sometimes that there was a little whisper in the background to it actually becoming a voice. So people were able to describe what's called this prodromal period leading up to a first episode. And so then this opened up the really exciting possibility of, well, could we identify this period before people got the first episode? So I developed this interview schedule, the comprehensive assessment for at-risk mental states, which included not just those sort of sub-threshold forms of positive symptoms, but all the other type of symptoms that people described as well. So sleep disturbance, mood disturbances, anxiety, and so on, that often co-occur with those sort of sub-threshold psychotic symptoms. So we did that, developed the at-risk mental state criteria. So we said, it was all arbitrary lines, but, if you reached a certain level on that, then your risk was high. We developed a clinical service. This is back in Melbourne, where we then went around talking to people like general practitioners and schools and university counsellors, said this is what we were trying to do. If you've got anybody who you're worried about, refer them to us. We'll assess them and we'll provide them with treatment if we think they're at high risk. So we did all this back in the 1990s, and we found that the people did have a very high risk of a first episode psychosis, and that then really took off around the world where people were interested in this area. And it's now taken off to such an extent here in England that early psychosis services are trying to detect these people as well, so that we can minimise the risk that they have the psychotic illness and treat them for their symptoms that they're currently experiencing. So the CAMS, the Comprehensive Assessment of At-Risk Mental States, is being used in all those services. And for the princely sum of £1, I've let I can't remember what it stands for, HSCIC, so they're able to distribute it all to all the early psychosis services who can then use it free of charge.
How do you kind of assess the results of the success of it? Because just like a gut reaction to it is that, if you get somebody that's experiencing certain symptoms, how do you, can you know that you've prevented the person from going further, or is it just, is that speculative, or, it's a kind of a just in case approach maybe with some people?
It's always the tricky thing when you're trying to show that you're preventing something, because of course it might be that it would never have happened in the first place. So that's why it was very important to do our initial study, which was to essentially see what happened to these people who we thought were at high risk. So we provided them with treatment in our clinical service, but nothing particularly specific. So a lot of it was just talking to me, and I don't have delusions that I have super healing powers. So it was kind of just a general type of talking to me, seeing how you were going. And about over 40% of those people in the early days actually went on to develop a first episode psychosis. So it was important to do that study so that we would kind of know what we were dealing with. And then the interest around the world was actually in trying to prevent that first episode. And so then it was, well, compared to that base rate of 40%, what are the rates of development of psychosis if you actually provide some specific treatment? So in the early days, there was treatment with actually low-dose antipsychotics, but also cognitive behavioural therapy. People have used fish oil as well. And the idea is always to compare it with what you would expect the rate of psychotic illness to be if you didn't provide any of that treatment.
So has there been a kind of a detectable decrease in the amount of people that have gone on to develop psychosis with this approach being implemented? So
what we found is that any treatment is better than no treatment. So that's been shown in several research papers. CBT is found to be effective in reducing that risk. So that's how we tend to frame it, rather than saying it's preventing psychosis, is that it's reducing the risk.
Okay.
But what's also happened is, as time's gone by, even for people really not having any specific treatment at all, but just kind of coming along to a clinic and being monitored and seeing how they're going, the risk has decreased in those people as well. It's not clear why that is. It might be that we're getting people earlier because people are more aware that this work's going on. It might be that we're getting better at providing non-specific treatments to people. Or it might be that people who would normally not have come to a treatment service have kind of now come along. So they might not have developed a psychosis at all in the past, but people are more aware of mental health issues now. GPs are more aware of this at-risk mental state thing. So people are probably being referred where they wouldn't have been referred before, and they probably have a lower risk than the people that we saw back in the very early days in the 1990s.
So prevention is, quite literally better than cure.
Oh, I think it is. Our critics say, well, these people would never have got the illness in the first place, so you're treating something that's not there. But you've got to remember that these people are coming along and they do have difficulties in living. They do have symptoms. A lot of them have depression, sleep disturbance, anxiety. These are not well people that we're seeing. And if we can treat them with supportive therapy or CBT, then we're not poisoning them.
No, of course.
We're not giving them something that's going to be bad for them. And if we can improve their lives, that's great. If they were going to develop a psychosis and we prevented that from happening, that's great as well. It's very hard to prove, as you said, that we're preventing something, but we are also treating the symptoms that are there.
Well, I suppose it'd be like smoking. It'd be like saying, well, someone might not have gone on to develop lung cancer from smoking. So, but it's still good for them to quit in the first place and to try and improve their life in general anyway.
Yeah, that's exactly right. So, you've got two foci. One is to improve their quality of life now, treat their symptoms that they've got now. And the other one is, preventing psychosis. You may or may not be preventing it, but if you are, and you can never tell, then that's great.
Okay, I want to move on to treatment options and not go too in depth in it because I will dedicate an episode to these later on. So, from a medication approach, what would be some likely medications that people would take, either preventative or when they're already experiencing an episode of psychosis, and how what does the medication do? Okay,
so for the people who've got the at-risk mental state, we really try not to use medication. So as a first line, it's best to really try supportive therapy and psychological therapy. So we may use an antidepressant medication, for example, if they've got very severe depression. But again, it's best really to start with using psychological and social approaches. Once somebody's got a first episode of psychosis, that's really where you're moving into the region of seriously considering antipsychotic medication. So again, some people might get better without medication, but actually for most people, the medication is very effective in treating those hallucinations, delusions and disorganized thinking.
Okay. With any side effects, or is it?
Well, unfortunately, the antipsychotic medications do have side effects, so it's weighing up the cost-benefit of using them, but they are very effective in taking away those very distressing symptoms. We would tend to start on a very low dose and really strive to have the person involved in making decisions about that. So giving them information about, well, these are the different treatment options. We would recommend this and this. These are the side effects that you might have, but on the plus side, it's 98% probable that would take away those symptoms that you're experiencing.
Okay. With CBT, I have to say, with somebody who's used CBT for my own, like with depression and anxiety, I struggle to see how it'd apply in the case of somebody experiencing a psychotic episode, because a lot of CBT obviously is kind of controlling your own behaviours and kind of reframing thoughts, but with things like hallucinations that are completely involuntary and delusions, is there a brief way of kind of explaining how CBT applies to fixing those things?
I mean, I'm sure you'll be able to talk to people who are much more expert in CBT for psychosis than I am. There's certainly evidence that it works, and we're currently conducting a trial that's looking at CBT for psychosis versus medication for psychosis versus a combination of the two. And certainly there are people who are able to respond to CBT without medication, it seems. So how does it work? One thing is to target the stress. So it must be very stressful to feel that people are out to get you. Another thing is to target the behaviours that tend to reinforce the symptoms.
Okay.
So, somebody, because they're kind of paranoid, they might only ever go out with Well, in Australia, it's wearing sunglasses, less applicable here in Manchester, where it's really having a hoodie on and sort of walking along in a sort of stooped position and looking suspiciously around at people. So really saying, well, why don't you try going out without your sunglasses or without the hoodie and see what happens? So it's sort of challenging those behaviours that reinforce the type of delusions. It's also letting people know that hearing voices is quite common, so that, you know, they're not the only one that this happens to, you know, that really ways of coping with those sort of symptoms. So there's a whole raft of different strategies that people use to try to get people through that. And then as the hallucinations and delusions and disorganised thinking goes, and that sometimes needs the medication to do that, then people can start thinking about, well, how are they going to prevent that from happening again? What does it mean for them that it happened in the first place? How can they manage the stress in their lives so that they can reduce the risk that happens again?
Okay. So of particular interest for me, as somebody that's just naturally kind of skeptical of medication, pharmaceutical medication. I never took any during the course of my own mental health issues. A big one for me was engaging in exercise. And I believe that you've been involved in a study applying exercise is it as a preventative measure or as for people that are already in the midst of a psychotic episode?
Yes, thanks for asking that question, Danny. So we used exercise as medicine for people with the first episode of psychosis. There's evidence from other trials in schizophrenia that exercise can improve well-being, mood symptoms, but also that they can reduce those symptoms of hallucinations and delusions and improve motivation and so on. So we thought that it was worth trying in the first episode, and we were really pleased to find that, firstly, young people with the first episode of psychosis are happy to engage in exercise. So a lot of cynics were going, oh, they'll never do it. But actually, you know, if you support people, if you can provide them with accessible, inexpensive ways to exercise, then they will exercise, and it improves a whole lot of things for them. So,
what was the methodology of the trial? Just out of interest, like how many weeks was it? What kind of exercise? The duration of exercise? That kind of thing.
Okay, so it was not a randomised control trial. So we went into the first episode, Psychosis Services, the Early Intervention Services, and said that we want to try exercise as treatment. So we asked people to refer us, young people with first episode of psychosis. We then sat down and talked to them about what sort of exercise they would like to do. So they got to really choose a personalised program. We had a PhD student and some research assistants who were conducting this. So they had a person who was around about their same age who would talk to them about what they wanted to do, and who would then, if they wanted to go to the gym, would actually take them to the gym. If they wanted to go for a walk, would come on the walk with them. We found actually that most people wanted to go to the gym. So we had Manchester United Football Club actually offered to let us use their program of joining in with their football. We had a dance club that we could access for reasonable rates. We had local community leisure centres saying that we could have Nordic walking classes and so on. But actually we found most people just wanted to go to the local gym. And we asked them about that, and it seemed a lot safer for them. They felt that if they were, running on a treadmill for 5 minutes, then they'd be able to stop, and they weren't, a mile from home, that they would be able to have the choice of weights or aerobic stuff. And so we had people going to the gym with them and helping them to build up their exercise tolerance.
And that was over a period of...
Oh, so it was a 10-week exercise program. So they usually did... The idea was to do 2 sessions of 45 minutes each per week over 10 weeks, with the aim of getting up to 90 minutes a week of exercise for 10 weeks. And most people did that. In fact, the average number of minutes of exercise per week that people were achieved was 107, so over what we expected.
And what percentage of people reported kind of improvement in their condition?
Oh, I haven't got the figures in front of me, but most people did. So most people had improvements in their symptoms, so their hallucinations and delusions, their motivation, their self-esteem, their well-being, their confidence. So people were talking about improvements in all those sort of areas.
So kind of just in closing, well, a couple of questions. One I missed out before, which I think is quite an important one, is it seems to me that psychosis has become a synonym for being violent, for violent behaviour. Somebody who is psychotic, they are harmful, they can hurt you. Mm. Is that a fair synonymity, if that's a word? Is it or is it rare for somebody to be having an episode of psychosis who is dangerous to other people? What's the kind of truth behind that?
Yeah, unfortunately, psychosis and psychotic illnesses and the word psychotic have been taken on by movie makers and so on to kind of have a connotation of violence and being very disturbed. And that's very unfair and stigmatizing. And I think, as you said in the introduction, psychosis is one of the most stigmatized mental illnesses, and it's very unfair that it is done so. What we do know is that people who have a psychotic illness are more likely to be victims of violence than to be the perpetrators of violence.
Oh, wow, okay.
We also know that if people if they have their illness managed well, then they're no more likely to be violent than anybody else. Where there is the risk is where somebody has a psychotic illness that's not being treated, and where they might, for example, have thoughts that, person X wants to harm me and is trying to kill me. They might go and attack person X. Or if they've got a voice that says, you must kill somebody on this bus, then that's a risk. But that's only when the psychotic illness is not controlled, and it's only when they've got those particular thoughts. So it's a very small minority of people with psychosis are at risk of violence. So it's not nothing at all, but it's only when their psychosis is not being treated. So
it is an unfair association then,
yes,
in general?
It's an unfair association, and in fact it's extremely unhelpful, because the more people say, psychosis, that's, really these horrible, violent type people, then you're putting people off getting treatment.
Of course, yeah.
So we need to say psychosis is a mental illness like any other illness, that people do get better, the treatment works, the rates of recovery are high, they're no more likely to be violent than anybody else if they're getting appropriate treatment. So it's more helpful to think of it like that than to have these sort of stereotype views.
Yeah. And the final question is, I'm hoping it's going to be a hopeful one, is, and again, I think this is a kind of a stigmatizing assumption, is that people see psychosis as a cliff edge. You go off the deep end. Once you've gone, there's kind of no coming back. And so, what is the prognosis like? Bearing in mind all the treatment options and stuff, what is the prognosis? Can people make a complete and full recovery from a psychotic episode?
Yes, people can and do recover from psychosis. So we do find sometimes people will have one episode, they'll get better, they'll go back to how they were before, and make that complete recovery. Some people have less degrees of recovery than that, but recovery really is when people can feel that they can have a satisfying life, can contribute to society, can have a meaningful life. And some people can do that even while experiencing psychotic symptoms.
Okay, perfect note to end on. Alison Yung, thank you very much.
Thank you very much, Danny.
Okay, once again, if you'd like to comment on anything we've talked about during this episode, you can do so by going to myownworstenemy.org/podcast. If you haven't already, you can subscribe to this podcast on iTunes and Stitcher. Type in My Own Worst Enemy and we should pop up there. If you'd like to contact me, I'm at Danny D. Whitaker with 2 T's. That's on all the social medias, although you'll probably only get an answer from me on Twitter, if I'm honest. You can also email me at danny@myownworstenemy.org. Also, don't forget to join me next week when I'll be talking to David Burns from Stanford University. He's the author of the best-selling book, Feeling Good, The New Mood Therapy, which I think a lot of you probably going to be familiar with. I think it's sold something like 4 or 5 million copies by now. It's something ridiculous like that. And he also, this is the guy and this is the book which helped popularize CBT therapy back in the early 1980s. So we'll be talking to him about that, about his book, his career, some of the basic concepts of cognitive therapy, and all kinds of other things. So until next time, ladies and lunatics, behave yourselves, but not too much. And I'll see you next time.